So I'd like to talk about how we handle this little arrhythmia from a comprehensive standpoint, which may or may not include catheter ablation as part of its solution. And we touched on these statistics a little bit earlier, but the relevance of atrial fibrillation, very high and growing. 2.2 million patients in the United States having atrial fibrillation now, with that prevalence anticipated to exceed 12 million by 2050. There's an increased risk of ischemic stroke, 5-fold. This accounts for 36% of strokes in the age 80 to 89 population. And we recognize that strokes in Afib patients are more disabling, more likely to recur, and more likely to be fatal than strokes due to other causes. So it's a big problem. Very importantly, symptoms. Patients actively suffer from atrial fibrillation. I call it specific symptoms. If it's like palpitations, people are like, my heart is, I'm out of rhythm, I can't settle down, you know, and it feels like there's something inside of them and they're going nuts. You'll meet those people. And then you'll meet people with equally as important symptoms of just fatigue, sort of non-specific, but I just feel wiped out all the time, you know, and they're in Afib at 110 beats a minute and they're always in atrial fibrillation. For me, those people are significantly fatigued due to atrial fibrillation, and I'll take that symptom as seriously as I do the very active symptoms of palpitations. For the cardiologists in the group, we know atrial fibrillation can exacerbate heart failure, cause heart failure. We all have tachycardia-induced cardiomyopathy in our populations due to Afib. And also, we know there's a certain incidence of inappropriate ICD shocks due to atrial fibrillation, indicating that Afib with RVR at times in ICD patients is truly a problem. And we recognize, as does industry, that ICD companies have a difficult time actually discriminating between atrial fibrillation and truly malignant ventricular arrhythmias, causing the devices to choose to shock these patients because they can't tell whether that rhythm is actually coming from the ventricle or the atria. So our guidelines for catheter ablation for atrial fibrillation, and this is from the Heart Rhythm Consensus Statement in 2012, as well as Circulation 2014. If you have symptomatic atrial fibrillation, meaning the palpitations or the profound fatigue that is refractory or intolerant to at least one anti-arrhythmic drug, in the paroxysmal patient, you have a class 1 indication for Afib ablation. If that's a persistent patient, our indication is class 2A. For a patient with symptomatic atrial fibrillation who has not tried an anti-arrhythmic drug, they don't want to, or there's a reason not to, we can still take them for ablation in the paroxysmal case as a class 2A recommendation, and in the persistent case as a class 2B recommendation. So we see by guideline criteria, there is a significant role for catheter ablation for atrial fibrillation, both with and without the use of anti-arrhythmic drugs. So this is a paper from a newspaper article that was published in the Tri-Cities Herald this past April, just announcing that our program had begun at the Cadlick Hospital. We were very proud of that. And this was us actually setting up to perform an ablation procedure for atrial fibrillation. So this is myself and one of our very senior scrub techs from Spokane who made the move to the Tri-Cities with me. And here's our patient and our catheter system and the monitors that we use. We're performing these under general anesthesia right now, so the patient is intubated throughout. I can tell them the first thing you'll know is we put you to sleep. The next thing you know is that the procedure is over and you're going home the next day. And then in the meantime, I explain to them all of the steps of the catheter ablation procedure that we'll be taking. But nice to have that recognition, and that was our paper that showed up in the newspaper. So as a segue, what actually happens when a patient is referred for ablation of atrial fibrillation? And this is kind of our comprehensive management approach. And this can be helpful for our cardiologists who are managing Afib as well. You know, we start with the history and try to determine clinically what's our pattern. Is this a paroxysmal atrial fibrillation, meaning episodes are lasting shorter than 7 days, or is it persistent, where it's now greater than 7 days, cardioversion has been required, or chemical cardioversion has been required? And then symptom correlation. Is this person actually suffering from Afib or are they completely unaware of it? So I'm looking for, again, specific symptoms such as palpitations, and also non-specific symptoms, that persistent fatigue that is just superimposed on someone's life and really holding them back. Something to clarify and consider is the anti-arrhythmic drug history. Have they tried or been eligible for a class 1 flecainide propafenone, or maybe a class 3 dofetilide or sotalol, or as a last resort amiodarone, and those 5 really being the only antiarrhythmics that I use in my own practice. If you are thinking about a procedure, you're looking at comorbidities as for any procedure, and in our AFib patients, often that's obesity, obstructive sleep apnea. Is there other heart disease? Is there valvular heart disease? Do they have CAD or peripheral vascular disease that's going to interfere with catheter instrumentation? We think about this, and then in our AFib patients, we think about our anticoagulation strategy. Use the CHADS-2 or the CHADS-VAS risk scoring system, and then think through how you're going to manage. Whoever I get referred to, I can deal with the anticoagulation regimen that they're on. If they're on warfarin, we will ablate with a therapeutic INR. My preferred agent is Xarelto for anticoagulation. If you're using Eliquis or Pradaxa, we can work with either one of those agents. But you think through the strategy, because even if someone is CHAD-0 and all they're on is aspirin, for the 3-month following the ablation procedure, we're going to ask them to take something stronger, because the heart's a little bit raw from the procedure. We think the clot risk might be a little bit higher, so we're going to ask them to take one of the oral anticoagulants or initiate Xarelto for at least that 3-month post-procedure period. So we think through the anticoagulation strategy. And then what I really like is a monitoring guide to our therapy. How well are our drugs actually working, and did the ablation actually work? Did it really eliminate atrial fibrillation? We expect on a drug or after ablation that any residual AFib is going to have a very different symptom profile, and is actually going to be very confusing to the patient whether they're still having their arrhythmia or not. So having an objective monitoring strategy in place is really desirable. So pacemakers or defibrillators, if they already have one, it's going to provide you with some knowledge of AFib burden. And if not, I will frequently encourage my patients to accept an implantable cardiac monitor, which until this year was the Medtronic Reveal XT loop recorder, and now the injectable loop recorder, which is like the size of a vitamin pill. You just slip it under the skin. It'll tell you every whiff of atrial fibrillation someone has for the next 3 years of their life, whether they recognize it or not, and will truly be able to tell how effective our therapies are. So in the ideal scenario, when I have a patient who will progress to AFib ablation, this is my dream approach. Implant a loop recorder, obtain at least 4 to 6 weeks of baseline AFib therapy or AFib burden on whichever therapy they're on. We will do a pre-procedure CT or MRI to get the geometry of the left atrium to guide our ablation procedure. Hold the antiarrhythmic drug 4 to 6 days before the ablation so that it washes out. Hold Xarelto 1 to 2 days prior to the ablation. Then we actually perform the ablation, reset the counters on the loop recorder at the time, so it will now start to monitor post-ablation, restart Xarelto and our antiarrhythmic drug on the evening post-procedure. Patient walks out of the hospital feeling fine on post-procedure day 1, continue the antiarrhythmic for 3 months post-ablation, and then stop it if there's minimal or no atrial fibrillation. If there's still appreciable AFib during that 3-month blanking period post-ablation, then we say, why don't you use it for another 3 and 6 months, and we'll reassess whether it's something we need to continue. And then most importantly, the patient returns to their referring cardiologist. In that, we're happy to perform the procedure, be as involved as we need to be. We have enough patients in our practice that we're not trying to steal patients from other cardiology practices, and I make it very clear to our patients who refer to us that they will be going back to their primary physician and will continue to act in a consultancy role with their care. So just a little bit to convince you about AFib monitoring. This is the new Medtronic Reveal loop recorder that we're using, kind of the size of a vitamin pill. This was available as of February of this year, approved by the FDA. And this is what we're using previously. A remarkable device, lots of patients in my practice have these. We now are implanting this as an alternative, and all of the diagnostic information, even more diagnostic information, with a much more convenient implant and a less invasive procedure. How well do the loop recorders work? They work exceedingly well as Holter monitors. And this is a graph comparing Afib burden, excluding Afib, identifying Afib, compared to standard Holter monitoring. And the loop recorders do every bit as well. For the insertion of the new Medtronic Reveal LINQ monitor, Cadlick actually performed the first implant in Washington State on March 24, 2014. And it's really this idea of an injectable monitor, subcutaneous. You're not trying to go down onto the pectoral muscle like you would for a pacemaker or a traditional loop recorder. It's really superficial under the skin using this trochanter-based delivery system. It's a small incision, advance the trochanter or this probe subcutaneously to hub. This is the loop recorder sitting in the cartridge, and then we'll simply inject it with a plunger under the skin, a drop of Dermabond glue. The patient goes home 30 minutes later, and we will know all the atrial fibrillation for the next 3 years. So here we are with this small incision that's immediately post-procedure with the Dermabond glue covering, and then at office follow-up on post-procedure day 17, just this little scar here without any obvious evidence that a monitor is even present under the skin. Here is, at the time of implant, recording a 0.57 millivolt signal. Here's the electrogram that loop recorder sees, and then I can program atrial fibrillation detection on, and away I go. Every whiff added up automatically, whether the patient chooses to interact with their loop recorder or not. And just under fluoroscopy, here we see the new loop recorder, the LINQ, under fluoroscopy, and how that would compare to a Reveal XT. And both of those really minimally invasive monitoring options, the new LINQ being even that much smaller. The kind of data we can obtain, here's a patient. So we have a 66-year-old man, no structural heart disease, prior DVT-PE, lots of those, Afib with shortness of breath and fatigue, uncertain burden, being treated with Xarelto. So he actually got the Medtronic Reveal XT loop recorder in March of 2013. It showed 20% Afib at baseline, down to 0.7% with flecainide therapy, so very good. The patient believes he has blurry vision with flecainide. He wants to stop flecainide, and he doesn't want to try other anti-arrhythmic drugs. So we stop, and then with the loop recorder can see that he rapidly transitions to a persistent pattern of atrial fibrillation, and then we can advise him in a very informed way that if we're going to achieve any control of this at all, he better progress to an ablation procedure. So here we see the type of data that you get back, 14% Afib burden between July and September, and then stopping the flecainide, increasing to a 71% burden in September and November. We can see that most of his episodes start between noon and 6 p.m. with a certain onset of atrial fibrillation first thing in the morning, corresponding to his cortisol surge. So to understand these charts, here's 24 hours in a day as we go month to month to month, that axis being down here, April, May, June, July, August, September, and we see that on flecainide, just little whiffs of atrial fibrillation right up until the time we decided to stop that medication, and then he continued to have no Afib until you see the paroxysmal pattern with 24-hour episodes beginning to increase, and then at this time point in November, he transitions to a truly persistent pattern where his Afib is continuous. Without a loop recorder, it'd be very hard to know that and tease that out of a patient's data just based on history, intermittent monitoring, or ECGs, and it really helps us advise this person that they should progress quickly to a more aggressive strategy if they hope to achieve any control of their atrial fibrillation. Another patient I'll ask you to consider, 70-year-old male. He's had ablations for Afib in 2007 and 2011 at another center, not by me. He's been treated with amiodarone, flecainide, and Tecocin in the past, so a huge anti-arrhythmic drug history. And now he has recurrent Afib. He's not sure how much, variable symptom correlation, although he's sure he has symptoms. So we give him the implantable loop recorder to allow med titration. The patient loves that quantitative approach to AFib management, loves to know that we can know how much AFib he's having, and presently he's debating his third ablation procedure. So we put in the monitor, get a sense of how much he's having, 57% at baseline, episodes starting typically at 9 a.m. and 9 p.m. Interestingly, that's right when he takes his twice daily metoprolol. So breakthroughs of his drug therapy demonstrated by the monitor, heart rate during his AFib being poorly controlled, a lot of it being 100 to 120, 120 to 140, so we would benefit a lot from slowing him down. And then you can see individual episodes, the electrograms the device sees, a lot of data here. So we can start to adjust his therapy based on solid data. We chose to restart Tikecin, and you can see his heavy paroxysmal persistent pattern here, and then with the Tikecin loading, how that pattern became interrupted. Still 24, 48, 72-hour episodes, but you can see much less of a burden than prior to the drug. You know, I never would have expected a pattern like this. This is what he demonstrates. For the times that he's in AFib, I get a heart rate histogram, which allows me even to adjust his beta blocker to achieve a better response. So we can reduce his AFib burden from 22% to 14%. Here's a typical episode transitioning from sinus to an atrial tachycardia, which will then degenerate into the arrhythmia of atrial fibrillation, this episode lasting 82 hours. For example, in this particular patient. So what happens now in these patients who we really feel like we understand their AFib and we decide that an ablation procedure is optimal management for them? We like to begin with imaging, a CT or an MRI scan of the left atrium to really understand the left atrial chamber in that patient to guide our ablation procedure most safely and most efficaciously. We use that image. It's not just something we look at. It's part of our mapping system. We will take that CT scan, peel away layer by layer the extracardiac structures until here's our left atrium, prune away the pulmonary vasculature until we have our left atrium with our 4 pulmonary vein insertions. And really the backbone of our ablation strategy is to electrically isolate each of those veins, so we want to know their exact size and shape, how they insert into that chamber, whether there's accessory veins, how big that chamber is, if there's dangerous structures that are close to them, so that we can really do an effective job without putting our patient at any extra risk. So here we see our mapping system. This is now an electroanatomic mapping system created with our catheters, and I'll explain that, integrated with our CT scan that can identify critical structures such as the esophagus that we want to avoid, as well as other vascular structures. This is photos from our Electrophysiology Lab at Cadlick. Here we are starting an ablation procedure. We have our intracardiac echo, fluoroscopy, live electrogram monitoring, our electroanatomic map. In our control room, we've got our additional technicians, a representative from the CARTO company, our mapping company, expert in arrhythmias, is present for every single ablation case that we do. So a lot of brain power and technical expertise in our room. The ablation procedure is, of course, putting catheters in the heart. With our ablation catheter, anywhere we move it in the heart, the computer system remembers where that catheter has been. So here we are moving through the IVC within the right atrium into the SVC, and the catheter will recreate the shape of those chambers as we move throughout the chamber. The backbone of an AFib ablation is, of course, pulmonary vein isolation, which is a left atrial procedure. To cross to the left atrium, we have to go transeptal. So on fluoroscopy, we'll have this long transeptal needle, and here you can see it tenting on the inner atrial septum. With our intracardiac echo catheter, looking from the right atrium into the left atrium, you can see that needle tenting on the fossa ovalis as it prepares to puncture into that chamber. We will poke across that wall, now have catheters in our right atrium. The mapping system, which is CARTO, will remember the trajectory of our catheter as it crosses from right to left atrium. Should we ever lose transeptal access, we know exactly where we crossed, and we can do it without using the needle a second time. And then in the left atrial chamber, we'll use that mapping system again to define the anatomy of that chamber, each of the pulmonary valves, and to record and document our ablation procedure, which are the little red dots, as we go circumferentially around each of those pulmonary veins, achieving electrical isolation and effectively treating that patient's atrial fibrillation. So this becomes the working environment of our procedure. Everyone who comes for an Afib ablation gets exactly this routine. We can provide these images, happy to provide the images, explaining each person's ablation to our referring cardiologists if they are so interested. So again, a CT scan showing the atrium-related structures, that system reproduced with our catheter motion in the heart chambers, red dots, effective ablation to electrically isolate each of the pulmonary veins. We will use that mapping system to identify other hot spots in the atria contributing to the arrhythmia. We will ablate those. We have a computer system guiding the motion of our catheter. Here you see a heart, a pulmonary vein, our catheter, and what that image looks like on the corresponding fluoroscopy image. So you can see the agreement is pretty one-to-one. Allows us to come off the fluoroscopy pedal, save the patient, save ourselves from radiation exposure, and perform that procedure without subjecting any of us to radiation. Our fluoroscopy time for an Afib ablation, a procedure that can take 3, 4, 5 hours, is quite consistently under 10 minutes at this point, which is quite admirable. In fellowship programs, in contrast, where we're in a process of teaching people to also use fluoroscopy images, an ablation procedure will often take 60 minutes and above of total fluoroscopy time. So you're exposing the patient to that radiation. We're getting exposed to that radiation in the private practice setting where we can really hone our techniques and get better and better at our workflow. We're able to drastically reduce our fluoroscopic exposure to our patients. So it's a nice feature of referring your patients to a private practice setting as opposed to an academic setting, is that we can improve our workflow because we're not a teaching institution. Ablation of atrial fibrillation in the EP lab. This is what Afib looks like to us. These first 4 leads are your ECG. So there you recognize good old Afib like you would on any ECG. And then we have the catheters in the coronary sinus behind the left atrium. And you start to see that very fast, fractionated, irregular activity that's actually occurring in the atria during an Afib episode. And then for the catheter that's in the pulmonary vein, we see that the activation is even faster. So you see this very fast, rapid activation in the vein, which is fast but slower in the rest of the atria, which is then slower in its ventricular response. So identifying this as the fastest source of activation, we can say this Afib is probably really coming from, in this case, the left superior pulmonary vein. So we can ablate then around that pulmonary vein. And now on our 12-lead ECG, we will quite clearly recognize sinus rhythm. We'll see on our CS catheter that it's also sinus rhythm in the left atria. But for that catheter that's still in the pulmonary vein, we can see that atrial fibrillation continues. So in that, here's just a really nice example of how we've electrically isolated a vein. The driver or source of the Afib is in that vein beyond the atria. The atria is never aware of it, but it is still ongoing, and we've effectively protected the patient from the effects of that atrial fibrillation source and restored to them normal sinus rhythm. Our ablation will become more extensive in the case of a persistent clinical pattern of atrial fibrillation. It may now include lines across the atria. Typical lines are a roof line or a mitral isthmus line, perhaps isolation of the coronary sinus. So we think there's this big vein lying along the bottom of your atria, and veins are like hot spots of electrical activity into the heart. You know, you think the 4 pulmonary veins, there are 4 veins into the posterior wall of the left atrium, jet engines of electrical activity. Other veins also contribute. The coronary sinus below the left atrium, superior inferior vena cava, all those venous insertions can be sites of electrical instability, and often an ablation strategy to be effective will have to consider those as well. And a lot of these other ablation lesion sets that we may need to perform are a reflection of the contribution of the other veins that are influencing the heart. You know, let's not forget about the vein of Marshall becomes the ligament of Marshall, which used to be the left superior vena cava in embryology, still now a dry creek bed full of electrical instability that can contribute to that arrhythmia. So we're aware of all these things, and we're watching for them on an individual pace, on individual cases for each patient in AFib. You know, how is this person's heart actually generating this arrhythmia? And we can treat people very individually. Postoperatively, we talk about a 3-month blanking period where we're not going to count any recurrence of AFib as a treatment failure for atrial fibrillation during that 3-month period. That's why I always continue the anti-arrhythmic drug and caution the patient not to be too disappointed if they're still having AFib in that initial 3-month period when the ablation is still maturing. And we've had cases here of a persistent AFib still on postoperative day 2, you know, angry atrial fibrillation, a bit of an atac here, patient still very symptomatic. We're a partner with you. We're going to help treat patients, get them through these periods. We started him on Tikecin, and after his 3rd dose at about 11 o'clock at night, we see that atrial tachycardia resolving into normal sinus rhythm, which actually also settled down his ectopic activity and resolved his symptoms. We can then continue that through and we ended up stopping that medication in this patient, and he was free from atrial fibrillation there on out. You know, we're very aggressive about managing during these time frames, and ready to partner with any cardiologist to help find those ideal solutions. This is a favorite case of mine, partly because it's personal. A 64-year-old man, his wife had worked in our practice for decades. History of CAD, a stent years ago, preserved ejection fraction, AFib. He was actually referred for a pacemaker implantation and AVJ ablation because he was thought to have permanent AFib. So referring cardiologist had all but given up, said, how about a pacemaker and an AV node ablation, which is something we're very reluctant to actually do to make someone pacemaker dependent just to treat symptoms of atrial fibrillation. So lots of fatigue. We put in a loop recorder and said, let's try an anti-arrhythmic drug. We treated him with Tikecin and demonstrated in the presence of drug that his pattern was in fact paroxysmal with excellent symptom correlation. So this fatigue he had was in fact due to AFib, and we were able to demonstrate that and prove it in the presence of the drug, which became further justification that to treat this with ablation would improve that important symptom, which for him was fatigue. So we performed that ablation in October of 2013 and had the serendipitous result that he was entirely non-inducible for atrial fibrillation following ablation, and hasn't had any since. So here we are, we put in the loop recorder in the presence of Tikecin, 35% AFib burden, most of his episodes starting at 9 o'clock at night. And that's when his wife would say, that's when I lose him. You know, he fades away, his voice gets soft, he's, you know, less involved, aware. It made perfect sense to her that most of his episodes were starting at that particular time. So that really verified symptoms for us. We took him for an ablation, simply pulmonary vein isolation with ablation of complex fractionated signals throughout the atrial chamber, which the CARTO system really helps us identify those hot spots, and I'll show you a little bit more of those. Here we are ablating during AFib. This is AFib, the last beat of AFib. Afterwards, this becomes sinus rhythm. We're actually ablating complex signals anterior to the left atrial appendage after isolating the pulmonary veins. And following this break in the rhythm, his AFib was completely non-inducible. Here we are burst pacing from the coronary sinus at cycle length of 150 milliseconds with isopril on board under baseline conditions. We could not get Afib started in this individual at all, which bodes really well for success. And sure enough, on the loop recorder at the time of his ablation and there on out, no Afib. You know, you ask, well, is it recording anything? Yeah, it knows his average ventricular rate throughout his day. So he is in fact alive and his heart's beating. There's just no atrial fibrillation. And the computer can add us up and give 0. An excellent symptom improvement. You know, somebody who couldn't be more thrilled with the treatment he's received. And this is a patient, remember, who was referred originally for AV node ablation and pacemaker implantation for hopeless atrial fibrillation. And his final result being completely abolished atrial fibrillation. It's gone, he's in normal rhythm. He still has his AV node and he's off of his anti-arrhythmic drugs. So, you know, very satisfying cases that we can achieve in certain individuals, and that percentage of individuals in our practice seems to be just growing and growing. I'll just show you a few more. 61-year-old male, structurally normal heart. He'd had a flutter ablation in 2011, now persistent Afib. We gave him a monitor, we loaded him on Tikecin, converted his persistent Afib to a paroxysmal pattern, performed Afib ablation in August of 2013, pulmonary vein isolation, mapping and ablation of complex signals, isolation of the CS vein, confirmation that his prior flutter ablation was still providing block, and having atrial fibrillation abolished at long-term follow-up. So we implant the loop recorder. You can see his Afib is 100% persistent. Start Tikecin, and about 2 months later, Tikecin decides to start working, and it starts to break up his pattern of Afib into this paroxysmal pattern. That gives us courage that we can interrupt this rhythm and that maybe an ablation will be successful. So sure enough, we take him for ablation, and by the end of that 3-month blanking period, his arrhythmia is truly gone. We can stop Tikecin, and at follow-up, he continues to have no atrial fibrillation. You know, so another example of how effective this arrhythmia can be. And if you have the courage to implant a loop recorder or monitor and look for atrial fibrillation, you can prove to yourself, to your patient, to your referring, that the arrhythmia is effectively treated and eliminated in that individual. So it becomes a very satisfying part of our practice. We were just invited to submit an article to EP Lab Digest on our EP program at CADLIC, and I made it about our approach to ablation of atrial fibrillation, because I think for an audience at the national level, it is very interesting how we use the CARTO technology and the patient's arrhythmia characteristics and their monitor to really get the best result. So a unique approach to the ablation of atrial fibrillation happening at CADLIC Hospital in the Tri-Cities. That was the title of our article. You know, we begin with the ultrasound catheter positioned in the right atrium, imaging into the left atrium, and identifying where the left superior pulmonary vein and the left inferior pulmonary vein intersect. We want to identify that point. And again, this is something that only the CARTO system allows us to perform. There's many ICE catheters out here. Our ability to actually map and collect anatomical data with that catheter system is unique to the CARTO platform. Collecting those particular images, we can then take that patient's CT scan and drop it in anatomically correctly positioned perfectly into that right atrial map. So we have a perfect representation of the left atrium, correctly positioned anatomically in reference to the right atrium before we even put catheters into the left atrium. So we haven't even gone transeptal. So our procedure risk is still very low, and that means that when we do go transeptal, we know based on this image where our catheters are. So it becomes very easy for us to move our catheters throughout that chamber, recreate the dimensions of the left atrium in a way that reproduces very accurately and in one-to-one fashion what that CT scan had shown us previously. So we can move quickly, safely, and accurately within the left atrium. Having collected that information, As we move those catheters throughout the left atrium to define that geometry, those catheters are also recording at very high resolution the local electrical activity occurring in that atrial chamber throughout. So here we see each of these little points are where the catheter has sampled data. We can see at some sites activity within the atria is very discrete and actually not very interesting. Whereas at other poles of the catheter, at other locations, you'll have this very high frequency continuous activity, which we identify as a potential hot spot supporting the arrhythmia outside of the pulmonary veins. So we've performed this very detailed interrogation of the whole chamber, identifying where these candidate spots are located. And then knowing where they're located, we will perform our standard ablation lesions to isolate the pulmonary veins, now taking caution to pass through regions of atrial tissue that have the highest proportion of complex signals. So while we perform a standard ablation lesion set that would be performed in any lab in the country, we're also taking care to eliminate regions of maximally complex activity. And if you didn't take that step of mapping out those areas before you started your ablation, you simply wouldn't know where they occur, and you could put your ablation right next to them. You know, put it through regions of relatively benign tissue, thinking you were performing an effective ablation, when in fact the most interesting spots and the spots that really needed to be addressed were existing right next door and not being affected. So our strategy becomes a standard ablation approach that takes care to also address complex regions of activity throughout the atria that are likely supporting that arrhythmia. So I think what we achieve with a standard catheter ablation for AFib ends up in the long run being more effective in terms of eliminating that arrhythmia. Just by the way we've put together the different pieces of the CARTO software, the mapping system, and the way we're using them, I think, in a smarter fashion. And my sense is that that's in several ways particularly unique to our approach in our lab at CADLIC and responsible for some of the unique results that we're achieving. So it's a program we're really proud of, and I'm happy to, we love to do. We're averaging 1 to 3 ablations for atrial fibrillation per week at this stage, and getting very spectacular results. Patients always want to know if they can stop anticoagulation after their ablation for AFib. So you probably hear this a lot. What I'm telling patients is that it's absolutely necessary for 3 months following ablation. The guidelines are, of course, is that we continue anticoagulation as per their risk score, their CHADS-2 or their CHADS-VAS scoring system, even post-ablation, because we're very concerned about asymptomatic recurrences that have the same stroke risk. The patient will not recognize them. We won't know they occur until it manifests as stroke. So the recommendation is always to continue. I do think that now with loop recorder technology, where we can detect every incidence of AFib, I will consider making a deal with the patient to say, if we truly eliminate your AFib, and for as long as your monitor continues to demonstrate no AFib, we can allow you to come off the anticoagulation, perhaps. But the minute that monitor shows that you have a significant increase in atrial fibrillation post-ablation, you have to agree with me that you will immediately start your anticoagulation again. So I think with our strategy and in the presence of loop recorder monitoring systems, we do give patients the opportunity of stopping anticoagulation, whereas without that approach, I would never ever have the confidence to allow someone to stop their blood thinners. The recommendation, of course, for blood thinners in atrial fibrillation is very nicely summarized by this slide from Journal of Cardiovascular Electrophysiology in 2009. And what this graph shows just very nicely is your atrial fibrillation burden versus your CHADS-2 score. And as your CHADS-2 score increases, you need a lower AFib burden to warrant anticoagulation. And it really becomes a question of AFib burden greater than 24 hours or AFib burden greater than 5 minutes. And as your CHADS-2 score progresses to 2 and above, An AFib burden of 5 minutes and higher is something that does warrant anticoagulation. So the question comes up, we have all these patients with pacemakers, and it'll show you 10 minutes of AFib, 20 minutes of AFib, 3 hours of AFib here and there. They've not been started on anticoagulation. The practical question in our practice is whether we need to recommend this, and this table provides a very nice guideline for when that's necessary. If the CHAD score is significant, episodes lasting 5 minutes and above, the data suggests we really need to consider anticoagulation in those individuals. And of course, with my preferred agent being Xarelto, I'll say it one more time. So in summary, catheter ablation for atrial fibrillation can be recommended for symptomatic paroxysmal or persistent AFib. We can use loop recorder technology, particularly with the new LINQ technology, which represents an unprecedented opportunity for AFib monitoring and to know how well our treatments are in fact working. I think the Cadillac Providence EP programming is an outstanding option. We have senior staff. I'm not referring to myself. We have the latest equipment provided by Jim Bartlett. We do a high volume of procedures, and our safety record and our outcomes so far are excellent. And I'd like to consider this a partnership with referring providers. We're not trying to collect a bunch of patients from other practices. We really do need to send them back to the referring. We want to work with our referrings to, come up with the best solution for each patient, and we're happy to manage anti-arrhythmic drugs, perform ablation procedures, advise on anticoagulation, for any patient who's invited to us. And we do expect those patients to go back and be principally managed by their referring cardiologists. So I'd like to thank all of you for your attention to that program, in addition to our anticoagulation program. If there's questions related to this topic, I'd be happy to entertain. Yeah.
I see a lot of PAF, and it's just a nightmare to know how much they actually have.
Yes.
Whether your therapy is actually beneficial or not. There's frequent ER visits and all of that. So how often, particularly in the paroxysmal AFib, are you actually using the recorder to really help identify how much AFib and what your treatment success versus failure is? Should that be kind of close to standard therapy? You really have no idea how much AFib they're having.
If you really have no idea, but you do know it's bringing them into the emergency room, one or more times, then I think that's a strong indicator to me that monitoring can be appropriate. So you can really understand what you're dealing with and how much you're having. Because if you want to do a cost analysis, the cost of each of those ED visits compared to the cost of the monitor, and the monitor kind of quickly pays for itself if it can help you titrate therapy. And I think it can, even rate control, rhythm control agents, certainly if that person gets referred for ablation. Sort of the couch potato population who can't feel their AFib, they're never going to have an ablation, they come in, they're in AFib, the heart rate's 80, they probably don't need a monitor to tell you all about it, because you're not going to really adjust management for them. They're on a beta blocker, they have their blood thinner. I don't need to monitor them. For some people who are so symptomatic that they are absolutely debilitated by every episode they have, you probably don't need a monitor to confirm they're having AFib. But for those cases where you don't know, and where the symptoms are variable, and where AFib is proving to be a problem, and when you're considering a variety of therapy options, whether it's an anti-arrhythmic drug or an ablation strategy, I think having a monitor in place is invaluable. And talk about simplify your office visit. The patient shows up, you get the interrogation, you know all about their AFib, and you go in and you're not asking them, how's your AFib? You're telling them, this is your AFib, and this is how we improved on it since last time, and this is what our options are going forward. It makes it much more pleasant to handle those patients. And there's studies that show, even for patients with symptomatic, very symptomatic paroxysmal AFib, probably still 80% of their episodes are in fact asymptomatic if you did perform monitoring for them. So symptoms, even when symptoms are bad, tend to really underestimate AFib burden. And then I think we start to, the non-specific symptoms then tend to be underappreciated, sort of the fatigue, the reduced exercise tolerance, in addition to the florid episodes with palpitations, you know. So I think in those, the symptomatic AFib represents a little bit at the tip of the iceberg. And if I'm considering aggressive therapy like anti-arrhythmics, good likelihood that we'd progress towards an ablation procedure, I'm quick to offer and encourage the monitor. I mean, honestly, to put it in, it literally takes me 2 minutes. They go home 30 minutes later. I've got all that data for the next 3 years. I don't need every little episode, but when they come into the office, I can download, see what they've had since their last visit, make the therapy change, implement it, and go forward. You know, and this is something you don't need an EP to implant these. Our general cardiologist implant, it's very simple. It's designed to be simple. We're doing it in a procedure room, but it doesn't even need to be in the cath lab. So I think it's a great option, and I find that patients really like it. You know, by the time they get to their cardiologist, they're tired of, they've been to the docs who guess. You know, the family doctor is guessing how much AFib they're having. The internist is kind of guessing. How do you feel? How much do you think you're having? Is it any better since we changed your beta blocker? Oh, maybe, can't really tell. Like, everyone's guessing, and you can't know. But when you all of a sudden put the monitor in, you have this high resolution data that tells you all the burden, and for the AFib they're having, all about the rate control. You can tell when the episodes are starting, when they're stopping, see if that corresponds to drug breakthrough times, make, you know, informed therapy changes. And I find patients are really engaged. They really like the monitors, and they're, you know, the invasiveness of it is just hardly a consideration. So it's amazing how enthusiastic people are. I've actually been really surprised by that. So I like it, you know, and the LINQ particularly, you know, it's brand new. It's only approved since February, but it's really exciting. You know, the Reveal XT gave you as good a data for AFib, but you had to do a cut down all the way to the pectoral muscle, get it on the muscle, anchor it there so it didn't migrate, you know, 3-layer close so that you wouldn't have wound dehisce problems. So you needed the OR suite to do that, which adds burden to the hospital and a scheduling burden. Whereas the LINQs aren't nearly as complicated. Now they want it superficial. They don't want it on the muscle. They just want it several millimeters below the skin. You're never mapping to find where to put the unit pre-procedure. It's always in that standard anatomic location, which gets you satisfactory sensing. I mean, every time I've done it. So that, you know, the implant procedures are so much, there's so much less overhead, which is really encouraging. So if there's any additional comments, or Jim, I don't know if you have anything to say about explanations on CARTO.
Covered it very well.
So what we're looking forward to technologically in CARTO, the technology is available, and we're all waiting to have it in our hands, is what we call smart touch technology, where now the catheters, when they touch the wall of the heart, they'll actually tell you how hard you're pressing. And it turns out that having the right contact pressure within a certain range increases the efficacy of the ablation lesions tremendously. Right now, we think we can feel the wall of the heart. We can't be sure. We ablate, and we get the results that we do. Going forward, and very soon, in the weeks and months to start up, we'll know how hard that catheter is pressing on the wall of the heart. And sort of anywhere in the 20 to 30 grams of force range will pretty much guarantee very effective ablation lesions. And across the country and around the world, procedure safety is going up, ablation time is going down, because the amount of the ablation lesions that you do apply are just so much more effective. So even for experienced operators, the procedure time is really falling. The amount of total time of delivering radiofrequency energy is falling, and the results are very exciting. So we're looking forward to this and just waiting for our day in the sun when the production sort of catches up to the demand.